So I want to thank the Academy and Dr. Giusti for inviting me here to give this presentation. 14 years ago, I attended my first conference of Convocation as a first-year medical student, and never did I think that I'd be here in front of you, speaking to all the physicians, especially on this talk here, Coccydynia. So let's get into it. I want to thank you all. Disclosures, I have none. Coccydynia, what is it? And do you think this guy has it? So there isn't much information out there actually on what Coccydynia, what the research is, how to treat it. There's no really good, safe, effective methodology out there thus far. There are some books, there are some practitioners who've published some things. Here you have Dr. Foy. He's got a book, he's got a website, he's got some YouTube, and this was all based on Google, but there isn't much more. The other gentleman is Maine. He's done a lot of publishing on imaging and on treatment and surgical options, but again, he'll say the same thing. There aren't great options out there for patients with Coccydynia. So what is Coccydynia? It's tailbone pain. It's also referred to as coxalgia or Coccygodynia. It is localized pain to the coccyx. Overall, it's probably an underreported incidence, as it says in the literature. Most of it is because doctors don't evaluate it very well. They don't diagnose it very well. Patients come in complaining of pain in that area or the low back, and the Coccydynia is often missed. So these patients go a long time without actually getting a clear diagnosis and then some good resolution. Most common cause is trauma, but there are some non-traumatic causes as well, and we'll talk about those. There's a pretty sizable differential diagnosis. Includes falls, childbirth. Local trauma, you'll hear patients often say they went skiing and they had a fall, or snowboarding, or they got kicked. I hear that a lot with patients who play soccer. Bone spurs, arthritis, fractures, that's a pretty common one. It's a common one historically. When the patient comes in, you have to dig for it. The challenge is that oftentimes they forget it. They don't reveal that they've had a sacral fracture, a coccygeal fracture in the past. And then infections. One thing I don't want you to miss is cancer. One of the biggest things that'll hold you medically legal liable is a chordoma. These are primary bone tumors. They're seen in the neck in kids mostly, and in the spine, in the coccygeal area, sacral area in adults. They're about 3% of all bone tumors, 20% of all spinal tumors. And the big challenge with these that you want to miss is that it has a large metastasis rate of 30 to 40%. In adults, these usually present in the 50s and 60s. But there's reports out there of people in their 30s as well. This is an image of a chordoma. You can see here in the sacrococcygeal area right there and there. You've lost that definition of the vertebral bodies and discs. So for Coccydynia, patients say they come in, it's usually acute, and these really resolve most of the time. 90% of Coccydynia patients will resolve on their own, rest, ice, NSAIDs, and some cushions. There's multiple cushions options out there. You have the donuts, you have the wedge cushions, and you have these Rojo cushions, these wedge ones right there. Patients really like the Rojo cushions. You'll know someone who's had Coccydynia for a while because they'll come in with the Rojo cushion. It's significantly more comfortable than the donuts and more effective. The other thing you'll notice is that they'll actually come in with the airplane pillows that they use around their neck. You can flip that over and use that as well, just like these wedge pillows. So persistent Coccydynia, again, that 10% of patients that are challenged and don't resolve. These are debilitating, and that's the one thing I really want to impress on you is that persistent Coccydynia is really painful and debilitating. These patients really suffer, and so diagnosis is really key. The coccyx is a pelvic floor muscle insertion site, so your levator ani. They'll generally have a lot of spasm, a lot of bladder issues they'll complain about. They'll have difficulty with urination, or they'll say their stream has changed, and they'll say they'll even have difficulty breathing or getting comfortable down there, even with sexual intercourse. So treatment options are limited. There is pelvic floor PT. That is a thing. Multiple academic universities and private settings have pelvic floor PT. They will actually do intrapelvic treatments and do home exercises. Unfortunately, it doesn't resolve all cases. There's also surgical options as well and injections, and we'll talk about all those, injections being a last resort. But overall, there's no clear effective therapy in the literature. Omt Indications. So the biggest challenge here, again, we talked about is the diagnosis. One thing I really want to stress out when it comes to diagnosis is evaluate, evaluate, evaluate. Get your hands on the coccyx and sacrum. Do not be shy. Patients really complain about tenderness to palpation, and it's usually pain that's out of proportion to what either the physician or the patient would expect. These patients will also come in, frequently they'll say they've had a change in personality or attitude. Their spouse can no longer tolerate them, or they'll say they're emotionally labile, they have outbursts, they're crying more than usual. Family and friends will also notice that they have a personality change, and we'll talk about the reasons for that, but a lot of this is likely due to the autonomic irritation that comes from sacrococcygeal dysfunction. Excuse me. One other thing I want you to pay attention to is that they will, if you dig into the history, they will talk about a traumatic event most of the time, a fall, childbirth. Evaluation, this is a lot of words. So let's talk about how to really do an evaluation. So for palpation, I generally start out and I'll go along the sacrum and coccyx. So I'll find my PSIS as my landmark that helps me identify the superior portion of the sacrum, the sacral base. I'll find the lateral aspect, that lateral sacral margin. You're gonna have attachments of sacrospinous, sacrotumerous ligaments, and glute max, and other important structures as well. And I'll start at the very top, and I'll go lateral in the line of the sacral margin, in the plane of the sacral margin. I'm gonna palpate from lateral to medial and apply firm pressure until I contact bone. If these patients complain of pain, then I get more suspicious, and I'll palpate all the way down. Sometimes I won't have pain the whole way through. Oftentimes, you'll really notice it around the ILA and sacrococcygeal junction, and then down on the tip of the coccyx. It's really important to not just stop at the sacrococcygeal junction, but actually go to the very tip, and it'll actually come all the way down to the inferior most portion of the tip and place slightly anterior and superior. Next, it'll also come from midline. I'll go down each of the spinous processes, down the sacrococcygeal junction, and down on the tip of the coccyx. It really helps me to understand how to evaluate these and how to treat these patients with some case reports. So we'll talk about a couple of these now, and we'll talk about some of the treatment options and how they differ. These case reports were actually patients we saw in office. I had some medical students assist me over a summer, and so they helped with some chart review, some in-person, and some phone interviews. Consents were obtained. You'll see some images along the way. We have full patient consent for these images for educational purposes. So case one is a 20-year-old female and cheerleader dancer when she presented, but 4 years prior, she had an injury that started all this. When I saw her, she complained with low back and hip pain and headaches with blurry vision. She had multiple injuries throughout her complaints of coccydynia. She had 3 major ones, and then she landed in my office 4 years later. Her first injury, she was in cheerleader practice, 15 years old, and the spotters threw her up in the air. She did a flip. She came down through the spotter's arms, landed on her right hip and low back area. That was episode number 1. She then went to see a primary care physician who diagnosed her with mechanical low back pain, sent her physical therapy for 3 months. She was benched and was not allowed to play. After 3 months, they cleared her. The exact day they cleared her, she returned to practice. She did a very small backflip that was supported by her spotters. And she said she just landed with a little more weight on her right side than the left and noticed all of her pain come back. And now she had more pain as well that was on both sides, right and left hip pain. And then and she decided at this point, this was her second injury now, 3 months from her first, that she wanted to just play through this. She'd already been benched for 3 months and she wanted to continue forward. So she played on for 2 more years, cheerleading, competitively, pretty well in dancing. And then she had a third injury. At the age of 17, during a football game, she was doing some somersaults and backflips, and she landed on her head. It's hard to believe that this actually happened, but after this event, she actually started to complain of headaches and blurry vision, in addition to her sacrococcygeal and low back pain and bilateral hip pain now. And to illustrate this, that's actually our patient. It's pretty difficult to appreciate where her head is. So she comes in at the age of 20, 4 years into this, with low back pain, hip pain, headaches, and blurry vision. She's no longer even complaining of coccydynia or sacrococcygeal pain. So on evaluation, that same exam we just talked about, she had bilateral sacrotuberous, sacrospinous, and lateral sacrococcygeal ligament tenderness. So all we did was palpate along the lateral sacral margin and the spinous processes down midline. And she also had hypertonicity of glute medius and the psoas muscle. This is in addition to the traditional osteopathic exam. She also had a strong SBS compression, which I was wondering, all right, this may be a reason for the headaches. And we tried treating that, and it didn't work at all in that visit. I could not get rid of the SBS compression no matter what I was trying to do. Her sacral pain continued. I saw her a few weeks later, and we opted for a different treatment. So I'll go back and I'll say at the first visit, we talked about her sacrococcygeal pain. She was pleased because this was the first time she said someone has ever addressed her sacrococcygeal pain. And she remembered that that was her initial complaint. She was a 20-year-old female. There's no reason to think why we can't treat her with some cranial or some traditional extrarectal OMT, and so we did. At the end of that treatment, we spent a while trying to go at it, and we couldn't get anywhere. Her mom was in the office, and we talked about, all right, if this doesn't resolve, one option is to do a transrectal treatment as well. And so they came back a few weeks later for visit 2, and this time she left her mom in the waiting room, came in and said, we need to do that treatment. And so we grabbed the chaperone, we did a transrectal treatment, and she was absolutely ready. She told me she needed to do it. And so the results. Palpation was painful, but just alone, before the treatment, her pain was a 9 out of 10. And she was having 2 to 3 headaches per week with the blurry vision. So this was a young female, right? She went from high school, she had difficulty sitting, she had difficulty doing homework, she really complained of difficulty with computer work. She then graduated, had a job working 8 hours a day on a hard chair, and was really struggling to appreciate a good quality of life because of her sacrococcygeal pain. These patients with a persistent pain, they cannot get comfortable on the chair. You'll notice that they move around and squirm a lot, that's why they have the pillows, and if they lean back while they're seated, it'll exacerbate the pain even more. So she knew this coming in, and 9 out of 10 pain, and immediately after the treatment, she was able to sit comfortably. Short term, she said at a week, she still had improvement. And then at 7 months, we did another diagnostic evaluation on her. She had no pain. We saw her again at 21 months and did another diagnostic evaluation on her, and again, no pain, 0 out of 10, persistent improvement. At this point, she was having 0 to 1 headaches per week. SBS compression was resolved, and she contributed the headaches to anything but her sacrococcygeal dysfunction. She contributed to stress or work or lack of sleep. She noticed that those initial headaches that she was receiving 2 to 3 times a week resolved immediately following the transrectal treatment. You might be wondering, like me, how does that actually happen? How does a treatment of the sacrococcygeal area improve headaches and blurry vision? And we'll get into that. But the overall conclusion of this one is 4 years of low back pain went undiagnosed as sacrococcygeal dysfunction. All right, so let's talk about the anatomy of how her headaches are connected to the sacrococcygeal area. I took a 40-hour basic cranial course, really loved it, enjoyed it a ton, and there's all this information and discussion of the cranial, sacral, and anatomical linkages. And I said, well, where can we find this in the anatomy books? And everyone said, well, it's there. And they said, you can look in Braze, or you can, try and put it together in Netters, but it wasn't really fully documented. And so that was always a struggle for me. And so what I want to do today is help put that together for you, and we'll talk about why. So the first thing we'll do is we'll look at the area down here. Sacrococcygeal, there are a lot of ligaments we talked about. Sacrotuberous, sacrospinous. You have a lot of ligaments here along the lateral margin of the sacrum, and you have a ton going down the midline as well in the sacrococcygeal ligaments. And then we're going to talk about how these all connect to the head. So I first want to thank Dr. Bill Kuchera, or William Kuchera. Many of you may know him from his textbooks and his previous education. He is still doing illustrations. He was kind enough to help me with this here, and we'll go through the details of this. So I like to think of the cranial to coccygeal anatomy in 3 layers. First one being the most anterior. So 3 8P layers. Most anterior one's going to start at the base of the occiput. Strong attachments of the anterior longitudinal ligament to C1 and C2 vertebral bodies. It's going to attach to the vertebral bodies and discs all the way down from the cervical, thoracic, and lumbar areas. It's going to have a strong attachment at the sacrum where just the name changes to the anterior sacral longitudinal ligament. It's just a name change, and that's going to go all the way down the sacrum as well to the coccyx. First layer. Second layer, base of the occiput again. This time there's a membrana tectoria, which attaches to the dural membrane, and that's going to attach through the foramen magnum, down the posterior longitudinal ligament. Again, strong attachments to the OA and AA junctions, vertebral discs and bodies, cervical, thoracic, lumbar, sacrum. And that posterior longitudinal ligament is going to come down the sacrum, and it changes names again to the posterior sacral longitudinal ligament. And down here, it's going to split. There's a deep and a superficial portion, and those are divided by the filum terminale internum, by the filum terminale externum. And that's right down here, and we'll get into that as well. And that's the green line. And then your third layer from A to P of cranial to coccygeal anatomy. So you have your brain, you have your spinal cord, you have the dura and meninges. It's going to come down all the way to the conus medullaris. That's going to turn into the filum terminale internum, which is going to run for about 15 centimeters, and that transition from conus medullaris and the end of the spinal cord is at L1, L2 in most people. Filum terminale for about 15 centimeters, and that's going to come down and change to the filum terminale externum for about another 5 centimeters, and that's going to have a nice strong attachment to stabilize the meninges down at the coccyx, posterior aspect. Here's a close-up of the anatomy as well, and we will talk about the anatomy in further detail in this afternoon's workshop. And you can appreciate anterior longitudinal ligament, posterior longitudinal ligament, membrana tectoria, and the dura. And same thing down low. Any questions so far? Okay. Here's another anatomical image, conus medullaris, filum terminale internum to externum. And one thing I don't want you to forget about is glute maximus muscle attachments on the lateral sacral spine. We'll just complete the anatomy here. Anococcygeal ligament is going to go from the distal tip of the coccyx down to the sphincter. And it's really formed of a raphe of muscles and fibrous tissue from the levator ani. Levator ani is a large pelvic floor muscle, 3 large components. And they're going to go from lateral to midline. Some are going to attach directly onto the sacrum and coccyx, and some are going to help form the raphe down the midline. Here's another view anteriorly. Here you can appreciate the anterior sacrococcygeal ligament. What's interesting about this image is you can appreciate ligaments going from the left to the right and from the right to the left anteriorly. And you can appreciate the lateral sacrococcygeal ligaments, sacrospinous, and sacrotuberous. One thing that you should also pay attention to, and you can appreciate really in the back there, is that lateral sacrococcygeal ligament. It's going to go from the ILA of the sacrum to the first coccygeal segment. First coccygeal segment has transverse processes, and that ligament can oftentimes be tight, torn, injured, or very sensitive in these patients. So is this for real? Is the anatomy we just went through actually accurate? And we're lucky and fortunate enough to have Dr. Susan Sandstring review this anatomy. I wrote it up, sent it to her, and she was really kind enough to review it. And who is she? So she is, if you can Wikipedia her and she'll pop up, she is the latest editor-in-chief of the 41st edition, the latest edition of Gray's Anatomy. And when I first went through this starting a few years ago, you couldn't find all this in one of the Gray's Anatomy books. I really struggled. I was using a British version, I was using the 36th edition, the 39th edition, the 40th edition, and I was piecemealing all this together. And I wrote all this up, and I sent it to her, and I said, is this accurate? Because I'm not sure. I'm kind of gathering this from a few different books. And she came back and gave a few comments, and she said, yes. And she said, why don't you just look at the 41st edition? Because now at this point, the 41st edition had come out. And so what I'll say as a kindness to her is, if you want an anatomy textbook that actually describes all this in detail, it won't go through it from the cranial to coccygeal descriptions, but it'll talk about all this anatomy in one place. That 41st edition will cover all of that. It is a large, large, large book, far larger than any of the ones before it. Treatment. So how do we actually do this treatment? We'll go through the details of that in this afternoon's workshop as well. This slide is up here to really emphasize the importance of informed consent. To go through the brief description of the treatment, do this in 3 stages. It becomes an active technique. This is actually a novel technique we want to write up. And because we're seeing patients who are coming from pelvic floor PT and who still weren't getting benefit, they were struggling. They found that the treatment there was painful and or too long, and we found a novel technique that was actually a lot more comfortable for patients. And I think this is why we actually see that cranial to coccygeal improvements in patients as well. So we'll go back. Treatment part 1. The patient is in the prone position, they're completely relaxed, and you slip a finger in to the rectum, and all I do is palpate for soft tissue anatomy. I don't even go to the bone. I'm looking for hypertonicity, I'm looking for tenderness, I'm looking for laxity, I'm looking for asymmetry. And I will treat the soft tissue structures. Most often it's myofascial release, and it's usually indirect. It's really comfortable for the patient. So first part is soft tissue. Part 2 is bone and dura. This is where it gets a little more interesting and fun. Patient will come into a sphinx position. They're up on their elbows, and now we've engaged the dura, that third layer, and we've engaged the anterior and posterior longitudinal ligaments, that anterior and middle layers as well. And we're going to have the patient move through a series of neck and head motions. That motion will depend on where we feel the restriction is and where we feel that restriction improve based on their head movements. So what does that mean? I'll ask the patient, where is it tender as I'm examining their sacrum and coccyx? I'll then find an area that's restricted and or tender, and then I'll ask the patient, all right, please flex your head all the way down, chin to chest, look up towards the ceiling, back to neutral, turn your head to the right, turn your head to the left, back to neutral, and side bend. So right ear to right shoulder, left ear to left shoulder. And I'm looking to see which of those planes and axes of motion engage the restriction. And the patients will notice it as well. They will say, oh my goodness, I had no idea my head was connected to my tailbone. And they will say, oh, that feels so much better. Oh, that gets really tight, based on the movements that they are doing. So we'll go through all these areas and again, do the exact same indirect treatment. You can do this indirectly or direct, however you want. Patients often found it more comfortable doing it indirect. And I'll have the patient gently move into the barrier slightly, just to the front door of the barrier, back off 15 to 30 degrees and back into it. And there's this dynamic barrier that happens, and we keep pushing the dynamic barrier till we get to the final barrier and we break through that. And then we go to the next area of restriction and treat that. Part 3 is a lot of words, and it's just like part 1. You're gonna go back to that same position. Patient is now back prone, completely relaxed, and reevaluate all the soft tissue structures and treat them as needed. Post-treatment evaluation, I always reassess my patients. I let them get clothed, I let them go to the bathroom, do what they need, come back and reassess, and I'm comparing for the exact same TART changes as previous. Any questions on case 1 on the treatment?
Can you go back a slide?
Go back a slide.
To the previous slide of part 3.
Part 3 is going to be just like part 1. Any other questions? All right, nice silent bunch. Case 2. Case 2 took a little more. She's a 41-year-old female. She came in with a complaint of 5 months of low back, waist, buttock, and tailbone pain following an overuse injury. She had already tried physical therapy, no benefit. She had been in the pain and spine clinic, had multiple steroid injections, no benefit. Upon further questioning, her history revealed that she had a partial coccygyectomy at the age of 15. She had fallen off the bed, fractured her coccyx. Her dad, a neurosurgeon, opted for a partial coccygyectomy at the time. And she said she really had no issues after that. You may be wondering, like I was, how do you actually get an overuse injury of the coccyx? I don't know if you've heard of these insanity workouts, these high-intensity interval trainings. She was doing these daily, and she said just by doing this in her living room daily, she all of a sudden developed this tailbone pain that wouldn't go away. So she came in, same exact evaluation, up and down osteopathic evaluation, then that sacrococcygeal evaluation, and same areas of tenderness as case 1, sacrospinous, sacrotuberous ligaments, lateral sacral margin, sacrococcygeal junction, tip of the coccyx, and psoas and glute. So the first visit, OMT, all extrarectal, no benefit whatsoever. Saw her about 6 weeks later, still without benefit, in a lot of pain, wasn't able to return to exercise. And this is someone who was anxiety provoked and said she controlled it by exercising every day. Still had a lot of pain and exact same findings. And so we talked about the same options, and she opted for a transrectal treatment. She came back 3 weeks later, again, no improvement. So at visit 3, we actually did an ultrasound in-office evaluation and put the ultrasound on her, and you could see that there was fascial tears along the sacrococcygeal ligaments. And so once she saw this, and once I was able, kind of already knew they were there from the diagnosis and palpation, I do prolotherapy, but once the patient saw an ultrasound, she was then convinced. So she opted for prolotherapy, so we decided to do prolotherapy at that visit, and we did a transrectal to help manipulate the coccyx back in place, hoping that the prolotherapy would hold everything in place. Followed up, she sent a message a week later after the prolotherapy visit and said she's finally getting relief. She came back a month later for her second prolotherapy visit, and then a month after that for her third. And she was in good shape after that. She was able to return to her high-intensity training and all her activities of daily living and exercise. So for those of you who don't know what prolotherapy is, we'll talk about this even more on Sunday. But we injected a proliferant solution, 15% dextrose, into the areas that were painful, the sacrospinous, sacrotuberous ligaments, lateral sacral margin, sacrococcygeal junction, the emphysesis, where the tendons and ligaments attach to bone. Again, these are all the ligaments that we injected, sacroiliac and the sacrococcygeal. So case 2, she initially came in with 7 out of 10 pain. She definitely did not have immediate improvement with multiple, 2 to 3 treatments of OMT. She had short-term improvement with OMT, but it didn't last, but she had better short-term improvement with prolotherapy at 1 week, and she had lasting improvement when we followed up with her at 4 and 18 months. In fact, her Coccydynia was 0 out of 10. She was now able to sit comfortably without pain, exercise comfortably without pain, and go about her daily activities. This was a patient who, again, presented with hip, low back, and buttock pain. She wasn't clear on if this was her coccyx or not when she presented, because she really had a lot of low back pain, but she knew it was involved. OMT alone didn't work, but again, this is another case to stress out. Even if they come in of low back, the patient may not be clear and/or the history may not be clear if this is coccygeal involved, but I'd again encourage you to evaluate it, especially in your complicated cases. Both of these indicate that further research into both prolotherapy and transrectal, especially a novel technique for transrectal, further research is warranted. To close up on other treatment options for Coccydynia, intradiscal injections, this is done in the pain and spine clinic. They'll go through the sacrococcygeal junction and inject the disc there. And there is a fibrocartilaginous disc between the end of the coccyx, between the end of the sacrum and the start of the coccyx. Unfortunately, they generally only get about 2 to 4 months of relief, and at 12 months, it's only 30% improvement. Other injections, so the ganglion impar block. This will generally provide patients good relief temporarily of not just their sacrococcygeal pain, but also those autonomic symptoms we talked about before, right? Those emotionally labile outbursts, the crying, the personality and mood changes that their spouses and friends complain about. And my opinion for that is that ganglion impar, this is the only place in the body where the right and left sympathetic trunk meet, right there. The pink eye right there. Only place in the body where this happens. And I said, is that really accurate? Asked Dr. Stansring, and she said, yes, only place in the body where that happens. So anatomically, cranial coccygeal dysfunction, sacrococcygeal dysfunction, can not just cause physical pain, but it can cause an autonomic change as well. And imagine this over time with persistent coccydynia. Other injections, steroid injections, they'll go right into the area of the coccyx and inject steroids to hopefully get short and long-term benefit, and they'll do diagnostic lidocaine injections as well to help with diagnosis. Coccygyectomy, again, we talked about this being a last result 93% success rate if it's a luxation or a hypermobility. And that's specific to greater than 25 degrees, and we'll talk about how to evaluate for greater than 25 degrees of hypermobility. But if it's not 25 degrees or more, the success rate is poor. It's about 30%. The recovery for these is miserable. It's about 4 to 10 months, and patients are in a lot of pain. Imagine having surgery down here. They struggle to sit for quite a number of months after. So how to diagnose a hypermobility case? Patient will be standing. You want them standing, everything completely normalized and neutral. That's why you have them standing for 15 minutes before you do the imaging. You just want the soft tissue and the sacrum to normalize as much as possible. You'll do a lateral film. Then you'll have them sit on a hard stool, have them lean back. However, you need to get them to reproduce the pain. And once that happens, you'll take an image as well, just like the standing lateral. Here's what it'll look like as far as a cartoon image. You're looking for subluxations. So this will be a subluxation, this will be more of a neutral, and this is a posterior subluxation, and that'll be neutral. Here's what it looks like on imaging. I don't know if you can see it. Here's one patient, here's a second patient. I'll help you out. That's standing, that's seated. That's patient 2 standing, that's seated. You can see the angle change. That angle change there compared to that. Here's case 3 and 4 of imaging. This is a little more challenging to appreciate. So it's a subluxation. We're looking right here. That's actually the coccygeal segment that is subluxed out of place. That's what it looked like standing. And here's the other case right there. This one's gone posteriorly. So the coccyx is anywhere from 3 to 5 segments. It can fuse and it can not fuse. In females, it's going to fuse later, likely due to the mechanics of childbearing and labor. But many patients, it doesn't fuse at all, and that's where you get these subluxations. For hypermobility, you'll see a standing image like this, and then you'll see the coccygeal tip is really anterior and anterior superior oftentimes. These are the ones where it's really important when you do your diagnostic evaluation to palpate along the spinous processes all the way down to the tip of the coccyx, and you really have to find the anterior, inferior, most portion of that tip and just put a slight amount of pressure superiorly to identify these patients and for the coccygeal pain. Can you guys appreciate this one? This is standing, and then there's the seated. Standing, that's your angle, and seated. Bone spurs, this was new to me. I saw this in the literature. It's about 15% of persistent Coccydynia cases. These are patients who actually respond pretty well to diagnostic lidocaine block right there at the bone spur. It'll look like a spicule in imaging. You'll see them on X-ray or MRI. And this will actually cause a bursitis, an inflammation and pain. And because of that prolonged and persistent Coccydynian bursitis, the coccyx will often feel rigid and hard. And here you have one. It's a pretty large spicule or bone spur right there. And then here's a fluid view. You can appreciate all the inflammation in white. Coccydynia. So we talked about this. The diagnosis is really challenging. And I say that because there are reports in the literature where docs will say these patients are hysterical, and they'll say it's in your head. And multiple physicians in the Coccydynia world have written about this, is the stigma and psychology of pain for these patients, is that they then really get told that it's all in their head and that they're making it up and there's no reason for this pain. And again, I'd really encourage you to help them out with that. It is really gratifying to a patient and relieving to know that it's not in their head and that the pain is there and why. And just the diagnosis alone can be just very beneficial for these patients. So does this treatment really work, right? We just gave you a novel technique, right, going from 3 parts, including movement of the head and neck. Somehow this patient's headaches improved. Makes sense when we think about the anatomy, but unexpected when you just think about Coccydynia in general. So we decided to do a quality improvement project. I work at the University of Wisconsin, or I did at the time. Big MD institution, had a number of academic colleagues, many of them MDs, who were sending patients over who were impressed with the results and said we should do a study on this and evaluate it. I will say that there is an MD physician whose daughter is actually in DO school. She is the head of the pain and spine clinic, and she's the one who does a lot of the sacrococcygeal injections, the ganglion impar blocks. That's her thing. And when I talked to her about this, I asked, well, how do you do this, and how do you diagnose it, and what do you consider effective? And we went through, and it was everything we talked about. But what I was really impressed with is she said, when we have them in the operating room right before the procedure, we will put a finger in the rectum and evaluate where that coccygeal tip is, and if we feel like it's out of place, we will manipulate it. And she said, usually if we have a medical student, we'll make them do it. But they know good enough that the anatomy and physiology and the biomechanics is really important, and that coccygeal tip has to be in place as much as possible. Back to our QI study. So these are really fun because they don't take the big headaches and rigor of IRB-approved research. You have to get IRB clearance to do a QI study, but they're far easier to do on your own patients right there in the office and to get a before and after glimpse. So we'll have a case series. We follow these patients immediately before treatment, immediately after treatment, and then at follow-up, and we give them a questionnaire. And again, this was IRB exempt. So we had 16 patients, 13 females, 3 males. Average age was 44, and the age range was from 24 to 64 years old. Average BMI 29, and the BMI range from about 22, 23 to 45. Duration of pain really varied, from about 4 or 5 months to 20 years, right? The average being about 6 years. Number of treatments. Most of these patients had only one treatment. 14 of these patients had only one. 2 of the patients had 2 treatments total. We're talking about transrectal OMT. Evaluation form was really simple. I want to know what's your pain, seated, standing, lying down, and walking. And I'm going to evaluate this immediately before and after treatment, and again at some point in follow-up. I'll also ask them, how long can you sit down for comfortably without needing to change positions? And that'll really give you an idea as well, because it's usually just a few minutes, 15, 30, that's pretty uncomfortable as well. Patients who say they only have an hour or two, I mean, I think I'd have to move after an hour of seated. Your patients with Coccydynia will really struggle. 10, 15 minutes is usually what they'll say. So here's the data. 16 patients, up top, laying down, seated, standing, and walking. And down low, we have before and after for each of those categories. This bluish-green color is showing you trends of improvement. The red is showing you either no improvement or worsening of pain. So we had 3 patients who either didn't improve or had a worsening of symptoms immediately after treatment. You'll notice that some of these patients, their pain level was at a 0, so they're not going to show any improvement. And what's really key in this is that all these patients seated improved. And that's the main thing you want to look at before and after, is what's happening to these patients when they're seated. So what does all that mean? Well, laying down, we had a 40% mean reduction from before and after treatment, immediately before and after. Seated, 55% mean reduction. Standing, 56%, and walking, 61%. And we had a big UW statistician review all this and go through all the data and make sure this was legit. So this is immediately before and after. What does it look like before treatment and at follow-up? And follow-up range anywhere from 4 to 20 weeks. And so these patients all either improved or had no improvement. And so this was impressive. Those patients we thought got worse actually ended up getting better down the road, which makes sense. A finger has been in the rectum. It's a pretty uncomfortable procedure. Tissue is going to be irritated. So if they don't improve immediately, that's okay. Follow-up numbers were even more impressive than immediately after, right? So laying down, these patients had an 82% mean reduction in pain. Seated, a 78% mean reduction. Standing, 62%. And walking, 50%. Any questions on the quality improvement study there? Again, a nice quiet bunch.
Was it a variety of treatments?
The question was it a variety of treatments? So this specifically looked at a transrectal OMT. So anytime we did transrectal OMT, that was it. That visit, that's all we did. We'd bring in a chaperone. We had to go through the questionnaire. It was also, because it's a more invasive procedure, I wanted to identify if these patients were actually improving from transrectal or from extrarectal OMT. In other words, if we need to follow up and do this, what do we need to do? Because I didn't want to have to do transrectal if we didn't need to. So we had to identify if it was necessary or not. Does that answer your question? Any other questions?
How far out did you follow them for follow-up?
Yeah, the question was how far out do we follow them? About 20 weeks for this QI study. I would still see them, we'd follow up, but I didn't get results. QI study still takes some people to help out and hand out the paperwork and a research coordinator sometimes.
An anatomic question?
Where am I looking for that anatomic question? Yes, hi.
Hi. The phylum terminale, I have some recollection and some recess in my head that that is a continuation of the pia rather than of the dura. Can you comment if I'm totally wrong or if I'm on the right track on that one?
So the
the follow-up would be, what would you do to connect the pia of the brain with phylum terminale if that were the case?
We'll actually go through that in the workshop this afternoon. The pia is going to invest, if I recall, the internum, and the externum is going to be the dura. And there's actually, I'll have image of that showing the investing fascia and coming in on the phylum terminale. Again, more anatomy this afternoon. Any other questions? All right, so I really appreciate the patient's voice when it comes to coccydynia. You'll hear patients how long they suffer, the challenges, and this patient's actually going to talk about what it felt like to experience a treatment as well. Let me know if you struggle with the audio.
Approximately a year and a half ago, I took a fall and hurt myself. So I went to my physician and she suggested that I potentially could have cracked my tailbone. So take aspirin, take Tylenol, alternate, use ice. And I did all those things, but I kept getting worse. I went back after 3 weeks and I was having trouble walking. I couldn't lift my leg to walk upstairs. I just couldn't sit. I wasn't sleeping at night. I was very miserable. I had been referred to PT through my physician's office, and that seemed to make things worse. I went to see a pelvic specialist in PT, and I had a muscle spasm, and she knew right away what it was and was able to calm that down with 2 or 3 visits. But in the meantime, I still can't lift my leg. I still can't walk any great distances. She suggested that I needed to see a different physician. Our first visit, he did some leg manipulations, and that helped a little bit. I went home and still proceeded to have a lot of problems. So I went back in and talked to this pain doctor again, and he had suggested that we try an injection. While it was an awkward place to get to, it really did seem to provide some relief. So I, again, went back to this pain specialist, and we did a different type of injection, and in, I believe, 3 areas. With the help of ultrasound, he was able to find what I believe were tears in a ligament and perhaps a tendon. But I actually went home and I was exhausted and slept, and when I got up, my pain was so much better. I thought, this is just incredible. And I noticed at some time that I seemed to be having 2 kinds of pain. I had an area that was very sore and very specific, and then I had what felt like bone pain. The ligament was better, that the bone pain was still there and persistent. And again, after about 6 weeks, I went in and my physician did a manipulation on that was incredibly helpful for the bone pain. This procedure was, the doctor put a finger inside my rectum And he had me move in different positions while he was feeling the movement on the inside of my pelvis, I guess. So I would have my chin down, I was laying on my belly, and I would look to the left and back to center and look to the right, and I could feel some type of, for lack of a better word, pull. It's a very subtle kind of movement, and it wasn't anything that I can say that I really understood, but I knew that there was a definite feeling that went from my head or chin to my tailbone. So when it was finished, I got up and I walked around because I could not believe that I didn't have any pain. And it was just pretty close to miraculous from my point of view, because for the first time in a year and a half, I literally was pain-free. It was just a few minutes, and the results were great.
This patient was a little different than the two case report ones we talked about. She actually had injections first, and they didn't resolve her pain, and then we ended up doing the transrectal OMT. Anybody recognize this image? No one. This is the 2018 ESPY Awards, Excellence in Sports. This was on ABC. Previously, this was on ESPN. These are the survivors of Larry Nassar, who received the Arthur Ashe Award for Courage. I've given this talk a couple of times in the past, and that always comes up, is how do you feel about doing this with that going on? And what I present to you today is research, anatomy, patients who are challenged. To me, they're two separate things. At the same time, they need to be completely respected. These patients, these survivors were a victim of someone who's doing unlawful predatory acts. It's really important to communicate informed consent and the benefits of this treatment with your patients when it's needed and if it's needed. And I'd like to talk about what that means and what is informed consent. So going back to the original literature on informed consent by Braddock, it has a few components to it, 8 major ones. You want to document the patient's role in the decision-making process, and not just document, you actually want to have that interaction. You want to talk about the clinical issue, the diagnosis of it, the treatment of it, the option for no treatment, and alternatives. You want to discuss potential risks and benefits, any related uncertainties. I tell my patients this may not work. We don't know. This is what we're seeing on exam. You want to get a clear understanding from the patient and communication back and forth, and you want to clearly have the patient's consent and preferences. I generally do not do this treatment at the first visit. I will educate them, and then they will think about it and come back. For all patients, male or female, I give them the option of, hey, do you want to see another provider? I was lucky when I was in Wisconsin. I was able to refer out to other osteopathic physicians. For the most part, if you communicate all this well and have a good patient rapport, they'll probably stick with you, and if not, that's fine. I had 3 years there. We had a number of patients beyond the study. One patient decided to go see one of my colleagues, and I was grateful because I was seeing her for too many other issues as well, that it made more sense. That was a more invasive procedure. But the communication is really key. I also, in addition to just the traditional informed consent, I'll talk about the procedure itself. I'll inform them in advance what the expectations are, the 3 parts, the head movements. I will also get verbal and/or written consent. So at the first visit, I get written consent. At the follow-ups, I'll do verbal. That's me. That's what we discuss at our university. And that's also what I talked about with our legal department. I spoke with one of the attorneys over at Michigan State and tried to get a little feedback from them, and they encouraged me to talk to our attorneys at the university as well. And this is the information coming down from legal. This is really the key. It's patient communication and documentation of that. And I take it one additional step. You actually should have a chaperone, technically speaking, for a procedure like this. And with that chaperone, they should do documentation as well, if you can. I was lucky enough at an academic university where we had an MA who would assist me, and they would chaperone, and I would ask them to document 2 things. 1, that they were present for the informed consent, and 2, that they were there for the entire duration of the procedure. When it comes to minors, that's going to be based on your state laws. So you need to look into that. And again, main things are what is informed consent and how is the communication and process in your state as far as documentation, legal guardian. My documentation always includes the informed consent, review of the procedure, goals of the therapy, alternatives, and risks and benefits. You really want to indicate the medical necessity for this treatment. And I'll document complications. I've had one, what I would consider a complication, and it was a patient who had 2 weeks of heavy menstrual bleeding and clots, and it went away. She had been having this pain for a long time. She was a tattoo artist and just wouldn't sit doing her work. She was in that much pain. And her, and we just continued to monitor it. She seemed to be doing well, and after 2 weeks it resolved. The other thing they'll complain about is tissue soreness. I mean, it is a transrectal procedure, so it is uncomfortable to some degree. But that said, I haven't seen any other complications thus far. That's the chaperone documentation we talked about. These are our references. A big thank you to Bill Kuchera, Susan Shandstring, a number of my students, and research coordinators.